tube thoracostomy is a life-saving intervention used to drain trapped air or fluid from the chest. But to successfully place that tube, an operator must puncture a dynamic, constantly moving structure packed with highly vascular tissue and vital organs. This 3D model of the thorax shows the severe internal risks of a blind puncture. If you enter the chest cavity too low, you risk directly lacerating the liver on the right side or rupturing the spleen on the left. Placing the tube too far posteriorly risks severing the long thoracic nerve, running straight down the lateral chest wall. Navigating these hazards is not a matter of applied force. Safe insertion relies entirely on a strict, reproducible, 5-step framework, beginning with the identification of the safe triangle. By respecting rigid anatomical constraints, an operator turns a highly dangerous thoracic puncture into a controlled, reliable surgical procedure. Step 1 is locating the primary target zone, the safe triangle. This is the only verified window through the chest wall's external defenses. This diagram shows the muscular borders of the lateral chest wall. The precise anterior boundary of our target zone is the lateral edge of the pectoralis major muscle. The posterior boundary is the anterior edge of the latissimus dorsi. We establish the inferior and superior limitations by targeting the 4th or 5th intercostal space. The operator must strictly remain above the 6th rib and keep the insertion point anterior to the mid-axillary line. These exact borders have clear clinical justifications. Staying anterior to the mid-axillary line protects the long thoracic nerve. Staying strictly above the 6th rib ensures you clear the upward diaphragmatic excursion and the underlying liver and spleen. Once the target is acquired, you select your tube. Modern clinical guidelines favor smaller 24 to 28 French tubes for most applications to minimize tissue trauma, discarding the legacy practice of using massive 40 French tubes. The French scale is a unit of measurement for catheters, where each unit equals exactly 1/3 of a millimeter in external diameter. The safe triangle is a non-negotiable anatomical constraint. If you operate outside of it, you invite catastrophe. Step 2 is the layered administration of local anesthesia and the initial incision. This cross-section shows the required chronological path of the needle. You form a superficial skin wheel and then drive the needle deeply through the subcutaneous tissue to systematically anesthetize the highly sensitive periosteum of the lower rib. From there, you execute a critical maneuver, walking the needle strictly over the top margin of that rib. You advance it slightly deeper to inject the parietal pleura. The parietal pleura is the thin outer membrane attached to the inner surface of the thoracic cavity, and it requires deep, targeted anesthesia. As you advance, you must continuously aspirate the syringe. A sudden flash of air or fluid into the syringe provides definitive confirmation that your needle tip has entered the pleural space. With the tract anesthetized, you use a scalpel to create the primary access point, a 2 to 3 centimeter transverse skin incision, perfectly parallel to the rib margin. Meticulous, layered anesthesia along this specific trajectory provides the foundation for patient compliance during the highly physical dissection phase that follows. Step 3 is blunt dissection. This phase requires rigid adherence to the over-the-rib rule. This close-up view of the rib reveals the primary hazard of the dissection phase, the intercostal neurovascular bundle. A vein, artery, and nerve run directly along the inferior margin of every single rib. To avoid severing this bundle, you apply firm, steady pressure with a closed, curved Kelly clamp, gliding it strictly over the superior margin of the lower rib. You maintain that pressure until you reach the tactile endpoint, a distinct mechanical pop as the blunt clamp pushes through the parietal pleura. Immediately, you spread the jaws of the clamp to dilate the muscular tract without cutting the tissue. This brings us to the mandatory constraint of the entire procedure, the 360-degree digital sweep. The operator must insert a bare, gloved finger through the dilated tract and into the pleural cavity. This allows you to physically feel the lung, confirm your intrapleural location, and sweep away any loculations. Loculations are isolated pockets of fluid or pus trapped by fibrous adhesions, and they will block a tube if not cleared. The digital sweep is your ultimate tactile verification. It completely replaces the dangerous novice urge to rely on blind, visual force to push a tube into the body. Step 4 is the physical insertion and directional routing of the chest tube. You clamp the most distal hole of the chest tube with your Kelly. This stiffens the flexible tip, allowing you to seamlessly guide it along the pathway your finger just verified. This diagram of the chest cavity illustrates the two specific internal trajectories. You direct the tube apically, upward and posterior, to drain air in the case of a pneumothorax, or you direct it basally, downward, to drain fluid in the case of a hemothorax. A pneumothorax is an accumulation of air in the pleural space, while a hemothorax is an accumulation of blood. Once the tube is routed, you must ensure correct depth. The final, most proximal drainage hole on the tube must be inserted an additional 3 to 4 centimeters past the inner chest wall. If you fail to achieve this depth, that proximal hole can easily slip out of the tissue. If it becomes exposed to ambient room air, it destroys the necessary water seal, and the lung will collapse again. Matching the internal trajectory to the pathology and securing the depth physically restores the negative pressure required to resolve the patient's condition. Step 5 is mechanical fixation. A perfectly placed tube is clinically useless if it falls out of the patient. You start the closure by using a heavy zero silk suture to throw a simple interrupted or horizontal mattress stitch. You tie this down to cinch the skin tightly against the circumference of the tube, closing the wound. Traditionally, operators used a loose crisscrossing tie called a Roman sandal. A superior method wraps the suture tails tightly around the tube 4 to 5 times in immediate succession, sitting perfectly flush against the skin. This factor diagram shows the physics of a self-tightening friction hitch, similar to a rock-climbing Persic knot. With multiple concentrated wraps, any outward tension on the tube causes the suture to automatically constrict inward, actively gripping the plastic to prevent slippage. An immaculate anatomical dissection accomplishes nothing if the apparatus isn't mechanically secured against the chaotic environment of a hospital ward. Finally, you connect the external end of the tube to the water seal drain. You reinforce the plastic adapter with spiraled strid-stick tape, ensuring you maintain visual access to the connection point for future troubleshooting. The entire protocol demands strict adherence. Target the safe triangle, ride strictly over the rib to clear the neurovascular bundle, then carefully perform the required 360-degree digital sweep, and finally lock the tube securely in place with a friction hitch. Mastering this procedure requires abandoning the instinct to rely on a visual, forceful puncture. By combining precise anatomical knowledge with strict tactile verification, practitioners turn a high-risk thoracic breach into a securely controlled, life-saving intervention.